Good. Okay. Well, good afternoon, everybody, and welcome to the fourth webinar-style Grand Rounds of Great Ormond Streets. It's been great to see so many people tuning in and logging in for the previous one. We've had up to nearly 500 people at some points, which has been fantastic, and they're the biggest Grand Rounds we've ever run. So, if you want to get CPD points for these Grand Rounds, then you can self-credit, which has been recognised by the RCPCH. You can have one CPD point, which is 45 minutes of teaching, and then 50 minutes reflection about the Grand Rounds. I'm going to introduce Joe Brierley, who is a consultant intensivist, paediatric intensivist at Great Ormond Streets, and he's had a major interest in paediatric bioethics for many years now, and he's assembled a fantastic team from the bioethics service to talk to us about ethical challenges in a pandemic. Okay, so Joe will introduce his team as we go along, or they introduce themselves. Fantastic. Over to you, Joe. Thank you.
Thanks, Jonathan, and everybody for putting this on. So we've got three speakers, two excellent speakers, and myself, and then a panel at the end to hopefully go through any questions you've got. So we're going to talk about the role of bioethics and a little bit about the work we've done as an institution and a group in our team during this pandemic period, which is obviously completely unprecedented. We'll start with Dave Archard, who is the chair of the Norfolk Council on Bioethics. He's an emeritus professor of philosophy in Belfast, and we've been really lucky to have Dave on our Great Ormond Street bioethics team for a couple of years now. And Dave's going to set some of the background to ethical considerations during a pandemic. So over to you, Dave.
Thanks very much indeed, Joe, and thank you for inviting me to do this. I'm going to speak without slides and make some very general remarks about ethics in the pandemic. Let me start by noting, as I and others have said repeatedly, and more so in the last few weeks, it's really important that the government does do ethics and that its strategy in the current context can be justified. As you'll know, the government continues to repeat the mantra that it is led only by the science. There is a need for ethics, even if the government denies it. And it rather reminds me of the famous remark attributed to Alistair Campbell when he interrupted Prime Minister Tony Blair by saying, "We don't do God." I think this government doesn't do ethics, but it needs to. There are two elements in doing ethics. One is institutional and the other is more prescriptive. So the institutional element is the existence of organizations such as ethics committees, which can interpret, support, and implement any ethical guidance. And those committees can exist at a national level or at a local level. What we do know is that the local level provision is extremely patchy. I don't want to say any more about ethics committee, though happy to talk at the end in the panel. What I want to talk about is the second element of doing ethics, and that's the existence of ethical guidance. And that guidance comes in a very familiar form, and you can find it in various documents that have been produced over about the last 3 to 4 months from official organizations such as NICE or a republishing of the Department of Health ethical guidance in a flu pandemic, through to organizations such as the BMA, the Royal College, then academic publications, and obviously ethical guidance can vary from jurisdiction to jurisdiction. The guidance that you will see takes a very familiar form, and it's that of listing. It's like a shopping list of key ethical principles. So you will find principles such as respect for persons, minimizing loss of life or suffering, maximizing the number of lives saved, or a principle of equity and fairness. I'll come back towards the end to talk about the existence of what I think have been some emergent values in the current context. Now, there are a number of problems with listing general principles, and I think there are at least 3 huge ones. Firstly, it's not enough to just list principles. You need to justify the ones you've chosen and explain why those principles are listed and not others. Otherwise, you invite the charge of arbitrariness. And relevant here is a famous joke attributed to the late, great Groucho Marx, who famously said, "Here are my principles, and if you don't like these, well, I've got others." Now, I should say that I'm indebted there to Honora O'Neill, who likes using that particular joke. So the problem with just listing principles is there's no explanation as such in the listing of why you've chosen those particular principles. Secondly, principles may well conflict. That is, you could have 2 principles giving different answers as to what we should do in any situation. And that means we need some means of ranking principles, of explaining which are more important principles and which principles maybe are trump ones that take precedence over all others. You need, in effect, higher order principles that explains the ordering of your other principles. And the third problem is that it's very hard to see, without a lot more work, how you move from general principles to making particular concrete judgments in any individual case. So, to give one example, if you take the very pressing question at the current moment about prioritization of scarce resources and what we should do to ration those resources, particularly pressing in the case of ventilators, you will find standard guidance saying things like, well, you should use a principle of equity or fairness. But that principle as such doesn't tell you precisely what you ought to do. And there are various ways you might interpret equity and fairness. So, for instance, famously, some people think that age is an appropriate way to fairly distribute resources, giving priority to the young over the old. So, principles generally stated in various documents don't seem to me to do enough of a job to explain precisely what we need to do in any particular case. I now want to look at what I think are some of the issues that have arisen in the current emergency. And it is an emergency in the way that one might think any natural disaster that suddenly afflicts a society is an emergency. And it's normally said in these kinds of cases, normal ethical life and practice is suspended and we need to go to a new regimen. I want to pick out what I think are four very interesting features of ethics in the current situation. The first is that the ethical issues go clearly beyond simple clinical practice. That is, they go beyond considerations of how doctors and nurses are making decisions. They involve broader public health matters and indeed beyond that, social policy as such. It's very standard if you read a history of the development of academic bioethics from the 1960s onward, to say that in the beginning, bioethics was essentially concerned with individual bilateral relations between a doctor and his or her patient, or between a researcher and his or her subject. Into the 70s and 80s, it broadened out to take on issues in public health, which very crudely is understood as issues that have to do with the health of the whole population. And you got discussion of issues like mandatory vaccination or involuntary use of chlorine in drinking water. And very clearly, in the current context, we are talking about, if we're talking about ethics, the ethics of general public health strategies and social policies. So to take one very obvious example, it looks like social isolation and quarantining is one essential element of a successful overall strategy to reduce the transmission of COVID-19. But a policy of social isolation has disproportionate effects on different groups within the population. And there will be some within the population who are really disadvantaged by social isolation. Those who don't have a second home and a car with a full tank of petrol. I mean, people who are old, vulnerable, bringing up children as single parents and so on. And it's an ethical consideration as to how we should support those individuals. So the first interesting feature about emergency ethics is that we have to take in much more than simple, narrow clinical ethics and look at the overall issues that arise from a successful public health or social policy strategy. The second relevant consideration at the current moment is that this is a global pandemic. In many discussions I've taken part in, people have said, is there any real precedent or parallel for the global character of this pandemic? And many people quote HIV/AIDS as the nearest they can think of, because previous pandemics, everyone thinks of SARS, Ebola, Zika, these were quite restricted and narrow in their application and the people affected. COVID-19 affects people indiscriminately across the world. And that means that we have to understand how to deal with it in global terms through global organization across borders. And it also means that if there are solutions in the long term to this particular pandemic, they're going to be brought about most expeditiously by global cooperation, most obviously in terms of the preparation of a vaccine. The third relevant and interesting consideration at play in the current pandemic is what one could call emergent values. That is, there are some very familiar principles or values that are in play in a lot of the ethics guidance documents, and some of them are very recognizable through what gets known after the university whose individuals started as Georgetown principles, things like autonomy, beneficence, non-maleficence, justice. But what you will have heard in discourse is appeal to things like trust, trustworthiness, solidarity, transparency. And that's very interesting because most people seem to think that if we're going to tackle successfully this pandemic, we need to have certain collective values in place, such as a sense of community and solidarity. Now, what's interesting is that the value of solidarity is very recognizable to European bioethicists. And I took part last year in a 10th anniversary conference of the Deutsche Ethikrat, the National German Ethics Council, on the last panel. And much play was made of solidarity. Indeed, it was there in the title of the session. And I had to politely point out that we Brits don't do solidarity. It's not really a value that we make much of, and is often absent from a lot of our ethical discussion. But it is a value we need to assess and understand properly. That seems to me also true about trust and trustworthiness that have been very prominent in recent days. But these terms, although they've been analysed a great deal by philosophers over the last 10 years, have not played a particularly significant role in bioethics. The last element that I wanted to draw attention to in the ethics of the current pandemic is the triumph of crude utilitarianism. It's very noticeable how in much of the ethical analysis you can find, not just in various professional and official documents, but in academic publications, is very, very simple utilitarian appeals to what produces, on balance, the best overall benefits over costs and burdens. And indeed, in discussion with American colleagues, I've heard it said, utilitarianism is the only doctrine in town in an emergency. Nothing else matters. It's just a question of numbers and saving as many lives as possible, not being particularly concerned with the lives we do lose if overall we can get a greater balance of lives saved. Now that's remarkable because back in the day when I studied moral philosophy at Oxford, it was the case that utilitarianism was the only moral doctrine in town. Kant was an obscure, in every sense, German who we didn't bother to read or even try to understand. And virtue theory wasn't taught at all. At most, you might find reference to Aristotle in classics, but certainly not in moral philosophy. Over the next few decades, utilitarianism was increasingly viewed as a highly suspect and defective moral theory that no serious person would support or endorse. And the only real options were versions of Kantianism or virtue theory. So it's remarkable to me to find this resurgence of utilitarianism in the discourse within ethics around the pandemic. And very little discussion, interestingly, of human rights, of the view which is fairly standard in moral philosophy that there are some things you should never do to any individual, even if by doing so you produce the best consequences. I've seen references to human rights in jurisprudence and in legal judgments around the pandemic, but very, very little in the ethics that's being used to discuss the current issues. I just want to finish by saying this. It's fairly common, though I think the principle has been put under severe pressure by developments over the last few days, that we will not engage in any point scoring or partisan political contestation. There is an emergency that needs to be dealt with, and when it's over, when we're on the other side, then we can return to the issue of what was done right and what was done wrong. I think it's too late to say that of ethics because so little has been done at an official level. But certainly when the pandemic is over, there will be time, I hope, for some distance from events and some calm reflection on what role ethics played in the strategy we adopted in this country to deal with the pandemic, how that was represented in various institutions, how it was represented in the advice and guidance given, and whether it was the ethically right guidance that was given and not just the scientifically right guidance. Thanks very much.
Thanks, Dave. Lovely. Okay. So I'm going to follow on from that. I'm going to talk a bit about what we did at Great Ormond Street. It's only on Wednesday, the 11th of March, that the WHO declared COVID as a pandemic. It's not that long ago. And for all of us, an awful lot has happened in that time. So I'm going to describe the bioethics team activity. So I'm going to go through a prelude, a bit about warning and organizational readiness, a bit about the hot activity that doesn't involve rapid reviews that we've undertaken in the last couple of months, and then a bit about recovery and where we're going from here. So the prelude. Vic Larcher from this institution, seems a different lifetime now, was involved with the H1N1 ethics documents with the Department of Health, and I was involved with the Ebola DH task force. So the GOS pediatric bioethics team have been involved with pandemic considerations and thoughts. And actually, it's only last summer I submitted with Sam Ray, one of the intensivists here, and Steve Playfall from Manchester, a paper to the Lancet arguing that we were very poorly prepared for a future pandemic in the UK. And our real concern was about the change in pediatrics, which most of you have experienced in the last decade. We have a huge number of children who probably were not considered during the last considerations of pandemics. So the ideas Dave's just touched on about who gets the last ventilator and what we do with overwhelmed resources seem to be the limits of discussions then. But since then, I mean, people will be involved in particularly our respiratory team with children with chronic lung disease and cystic fibrosis. Children with immunosuppression are far more prevalent in our hospital, whether it's post-transplant, more aggressive oncology, chemotherapy, which children do very well with. By and large, but also technology dependence, children living on ventilators. You've heard this before, children living at home with renal replacement, on parenteral nutrition. And again, now children at home with ventricular assist devices. Really no consideration about how a pandemic that affected children would affect this cohort of children. And then the other group that are more and more increasingly coming into the hospitals for treatment and then heading out are what we now call fragile children. Maybe children who've got palliative care needs, neuro cohort with frequent seizures, who might get an intensive care admission a couple of times a year to control acute deteriorations, respiratory or seizure related. And then we have increasingly, as GOS is a rare disease centre now, children are having very expensive treatments. And one of the old considerations in pandemics was, well, should we be even thinking about treating very, very expensive diseases, £1 million a year for a drug, when other people are dying from lack of ventilators? It's a very simplistic process to think about things that way. And our argument was that we really have to have a better way of thinking about this. And I don't think we were well enough prepared. But fortunately, as you've seen, the current COVID-19 pandemic has not affected children as badly as we feared it would. We had initial discussions with our Italian ethics colleagues because, as you're well aware, the pandemic was far earlier into Italy for lots of reasons. And it was very clear that children were not that severely affected in the early phase. And there were very few children in Italian intensive care units because of COVID. Preparing for this, though, we abandoned our monthly CEC face-to-face meetings and had set up a weekly lead Zoom meeting. The other thing we thought with GOS and some of the changes about how we've changed as an institution with more general pediatrics, with the other wards from other hospitals coming into the institution, we wanted a far more outward-facing ethics service. So we work with the critical care and paediatric networks, North Thames, South Thames, as well as Tadworth and the hospices, to try and bring ethics support that was available to anybody wherever they were looking after children, whether in the children's home as a nurse looking after LTV, whether you're in a district general hospital in the ED department looking after children, just to provide support for people where it doesn't always exist normally. We certainly were involved with the Drugs and Therapeutic Committee and the ID team, who did a fantastic job of preparing a process to think through novel treatments for COVID in children. Which drugs might be the most likely to help children who became badly infected, or may need different treatments for their huge problems in terms of the immune system becoming unregulated and getting out of control, which agents you might use, how you managed what went on. And we're also involved with all college documents about the pandemic as that evolved, and more about that later. And lastly, we established with teams in other countries a collaborative pediatric ethics framework, which is on several websites, to think through how we would work through the right approach to this. The documents on the right, you'll be able to access in the Great Ormond Street Pandemic Documents stuff online, including some stuff about how we should behave ourselves during this pandemic, some of our kind of behaviors as different medical teams, how we'd make sure we work with children and families to deliver the best we could and looked after each other, which is something we'll come back to in a while. Hot activities, well, the rapid reviews are certainly most of what we have done. There's quite a bit of educational activity gone on, working together with the European Academy of Pediatrics, our PICU societies, and also Boston Children's have had a collaboration, and we've been part of teaching the ethics of pandemics. Really lucky to do that with an international audience. We've also got involved with staff support, particularly Anne McNiven leads on that with the ethics team, and some of the documents on the right she has composed with another nurse from the Cleveland Clinic in the US, Georgina Morley, which are really useful moral distress documents that are available for people who are feeling there may be issues with some of the stuff they've seen, which might involve some of the people who've been to other institutions dealing with adults. A lot of the GOS staff have done amazing work going to help adult units around the London area, particularly intensive care units, and nurses, anaesthetists, intensivists have been helping there and have seen some pretty tough stuff. There's a brilliant welfare group that's been set up. I know Dal's on the call and she's been hugely instrumental in setting up great access to that for people, and we've been a small part of that. We've also put together a grant application to assess formally deployed staff. Go back to that. So hoping to get good news from the charity about that. The other activity, we're a reasonably well-established ethics group, and many institutions, it might surprise you, don't have any ethics support at all, some of them quite big trusts in London. And so we were approached by a number of institutions to help them set up, and we directed them to the UK Clinical Ethics Network, but also shared our documents. Mariana Dittborn, who's our amazing ethics administrator, who's going to be on the panel at the end of this, together with Hugo Wellesley to answer any of your questions, was instrumental in helping provide documents for other institutions. Some particularly wanted help in how to review difficult paediatric cases. The other role that I think was very important, there was a huge amount of concern from people in the community about perhaps changes in threshold. Dave's talked about this desire to maybe have utilitarianism and a frank who gets the last ventilator based on a number of criteria. And there was lots of concern from families at home with children with quite complex either neurodisability or organ support in other ways, that they might not be able to come into intensive care if their child either got COVID or got some other problem that might lead to an intensive care admission. And it was something we could reassure quite clearly. There's no change to the law, no change in current decision making, and actually there's been no decrease in children's intensive care capacity in the UK, despite teams being moved to other institutions to help look after. And that's a real testament to the intensive care teams at Great Ormond Street and other institutions who have worked incredibly hard, doubling up on call rotas, nurses working incredibly hard to look after children in very trying circumstances. And I think that just needs to be noted. But I think it's useful that kind of reassurance could go out that frank utilitarianism wasn't the way we were going, and the UN Convention on the Rights of the Child is still absolutely the way we think about children with their rights to treatment and care. To finish off, we are now moving to more of a reflection recovery phase. As I mentioned, that grant we're still waiting to find out about, hearing about staff experience, thinking about ways we can help in terms of future deployments, and to listen to how things have gone for those who've worked in other environments and how we might think about supporting them as difficult things they've seen might be something that causes issues in the future. Certainly advice about research has been another part of the ethics team's role during this period. The GOS staff blood study, we helped with the ethics of that, some of the COVID surface contamination studies, and lastly, the PIMS-TS UK studies that particularly our ICU team here, some of the consultants, May and Pascal, have been involved with the team here trying to describe that new entity, and we help think about how the ethics of getting consent from the parents to report that versus using registries was the way to go. And lastly, over the weekend, we had a wonderful chance to talk to the GOS Young People's Forum, you can see on the right, with Amy, who's amazing setting this up, and our chance to consider some of the difficult issues about going back, about re-emergence from lockdown and children's roles in that. And there's a blog on the JME site Vic Larch and I have composed whether children should be pawns, pathfinders or partners, and that's now accepted in JME as a consideration of how children should have a role in this recovery from the pandemic. Should they just be told when to go to school? Should they be partners in what goes on? Or pathfinders, the idea children should go ahead and we'll see if the infection rates go up. And we thought long and hard with children about that aspect of the pandemic, but also the other tough stuff they've seen. And hopefully that will lead to more work. My last recovery thought, children's issues during this pandemic have been hugely broad and not directly linked to COVID infection. And I think we are just starting to think and work through the psychosocial effects of lockdown. The effects on education, university are obvious, but mental health, some increased suicides in really sad cases with children, a number of the ICUs, and the effects of seeing the things we see in the press every day, which are very disheartening and concerning for particularly young children. We have seen noise about a rise in domestic child abuse, a suggestion that that's increased and incredibly worrying for all those involved with children, partly linked to the effects of lockdown and isolation and children not being able to be seen so easily when they would normally be seen at school. The poverty and recession aspects are really troubling. And I have to say, whenever there's a real problem with society and funding, pediatrics particularly does badly. And we already know there have been huge delayed operations, chemotherapy that's not been given on time or been amended, transplants haven't happened, and some of our specialist rare disease stuff has been pushed back. And how we emerge from this is going to be very, very important. I think we considered early on the Birkenhead drill, which some of you might have come across, the idea that we should have women and children first, perhaps a bit archaic now. But I think it's quite a nice reminder of how we think through children in our society. And here's the soldiers in Kipling's verse on the Birkenhead, which is a ship that sank off the coast of South Africa. And it was the first time the idea that we should have children as a priority was really pushed in our society, that soldiers stood back and let the more vulnerable people go on the lifeboats. Many soldiers died, they stepped back and allowed more vulnerable people to survive. And there's just a worry that actually, unless we think long and hard about how we behave, then perhaps children aren't going to be the forefront of our recovery. So that's me finished.
Thank you, everybody. That's fantastic. So, the panel, if you can all hear me.
Yeah.
So there's a few that have been promoted up the scale. I'll take them the most popular first. So just a general question about the protesters in the USA. I think Prof. Archard was talking about the importance of people's human rights during these times. And do you think the protesters in the USA are correct in protesting the fact that their human rights are taken away by the lockdown measures?
No. The most straightforward right to which they could appeal is a familiar American libertarian right of freedom. But even the American Supreme Court has long recognized that you can only exercise your liberty if you grant a similar liberty to everybody else. In other words, that you're not engaging in serious harm. What those robust individuals fail to acknowledge is that their exercise of liberty is extremely harmful to other members of the population. So no, I don't think there's a human rights issue there at all.
Fantastic. Well, that's very clear. Okay, so moving on, just regarding the BMA guidance about ventilation. I mean, the BMA guidance endorsed withdrawal of ventilation in order to benefit others with higher chances of survival. And I suppose if that was your grandparent and the ventilator was taken away from them, you might not agree with that. So what are the ethical views on that?
So I think that kind of reverse triage is really tough. And it's not, I mean, in terms of I isolated pediatrics and that, because we haven't had the same resource limitations during this pandemic, who knows in the future. It's a real hard ethical step. And it depends, of course, on how far overwhelmed your resources actually are. So if you're talking about a bomb going off, that's the time when most of these things with, I hope that's not something like that in the background, but when you go to really hard utilitarian calculations in the aftermath of a disaster, when you're trying to save as many people as you can, that's slightly different from the idea that you do it in a hospital electively. I think we've been very strong in saying that our ethical standard remains to do what is in the best interests of the person in front of us. It's hard if you have other people sitting outside the door who might have a better chance of survival. That has not been tackled very well in the BMA guidance, I would argue, nor in any other pandemic guidance to date. And we steered away from it with the Royal College guidance, with the nice get out that it won't affect children. It will need to be thought about long and hard. And I don't think it has been done well enough to date. But ultimately, if you remember back to inside the ethics committee during the last pandemic, such things were raised in a public arena quite well, and people were willing to listen to that sort of thing. But it has to be something where you keep the basic ethical tenets of justice, openness, transparency, and decision making that's fair with the right of appeal. They must all be available and provided. So it's a tough one. It's a good question, and I don't think we have a good enough answer yet.
Can I add two points to that? So one thing you've got to be very clear of, if you're doing that, is that you're basically on mortality predictions. You're saying that the new patient is going to do better than the one who's on it already. And there was an interesting thing from a while ago about pandemic planning. So it was like from before this pandemic, we're looking at how good your mortality prediction has to be to actually be better, to get a better overall survival than first come, first served. And actually, if your predictors of mortality are either poor or only decent, then actually you don't get a better survival. You have to have a very good mortality predictor for that to actually help. And the other thing is, just to echo what Joe said, there's an interesting article that came out recently about looking at all the looking from the state, so looking at all the guidance that hospitals have produced themselves, and looking at what's gone into that. And there's an awful lot on who should we, if you've got two patients for one ventilator, who do you choose between those? But they all fail to really tackle about the issue if someone's already on a ventilator and when you take them off. So it's something that people have tried to skirt, really.
I add one further point. The crudely, chances of survival on itself is not necessarily obviously justifiable, because you want to take account of how many years of survival, and you also want to take account of how many years of quality there might be. So there might be a better chance of surviving, but in a pretty awful condition. And what worried me from talking to at least one intensivist was some of the evidence that emerging of the damage that's done by being on a ventilator. So even if you come off the ventilator, the quality of life you might subsequently enjoy is very low. So I think the problem with all of these criteria is you need to moderate them, modulate them. And what you end up with is incredibly complex criteria, which is almost impossibly hard to apply in any particular set of circumstances when you've got to make a quick decision about what you do next. And the other thing quickly to say is, I think sometimes triage decisions get mixed up with rationing decisions. They are different. And what was particularly pressing in the current case is where you have patients with equal chances of benefiting from any particular treatment, but you can't offer them both treatment. That's when the really crude and horrible decision making has to be made.
Okay, thank you. And talking about qualities there, I mean, I think there's been a couple of questions about education, children, and our children's quality of life at the moment, when they're not allowed to go to school. And do you think there's what are the ethical arguments for opening school now, with the fact that it will have a positive impact on our children's mental health, compared to maybe a negligible impact to the increased spread of the virus? I mean, is there an ethical opinion on that?
Sarah, do you want to go, or do you want me to?
Yes, I think you're right, actually, that children have got left behind in the consideration of these issues. And particularly when they're saying, well, primary school children will go back and not the older ones, whereas actually it might be easier to put social distancing and reduction of risk in older ones. There's going to be a situation, we never have a situation where there's no risk. So there needs to be a balance of this. And I do think children need to rights and interests need to be upheld. And really concerning, as Joe mentioned, children who are in very difficult social situations, who don't have access to other activities. Indeed, the food issues have been brought up, not to mention abuse. So I do feel there's no voice out there for children at the moment.
Joe, can I ask what came out of your discussion with the Young People's Forum?
It was terrific. So I think a lot of the things you might expect, but some we wouldn't. And I think issues, I mean, Amy's on the line as well, actually. I wish you could chat in with us, who ran the thing. But I think some of the things were about the social aspects of what's gone on, about school, about going back. Some of the things about A-levels and having exams cancelled and university worries. Some of the access to healthcare. Some of the concerns broadly about society and what happens now in terms of jobs, funding, children who have less ability to cope with a recession, if you like. So lots of kind of very astute and thoughtful concerns about the larger social aspects of what's gone on, but also that idea about, you know, I'm a child, I'm a young person, I've got kind of certain rights. And we pushed a bit about where's your voice in all this? And I think only one young person had some sort of communication with the newsletter from any sort of representative democratic figure who was, I think an MP had sent something out and they could have gone on a web link if they wanted. The Children's Commissioner is trying to do some stuff, but I think the voice of young people, which we've got much better, I think in paediatrics, in terms of involving young people with research planning and funding, involving them how we build hospitals, how we think about things. There's been no kind of young people's voice and inclusion in what we do during a pandemic. And the other thing, Hugo, I think I was delighted to hear from some young people, because it's not just me that finds these briefings very hard to understand at 5 o'clock every day. There's quite complex stuff being talked about. And I think for some young people who are maybe 8, 9, 10, hearing that thousands of people are dying every day, what does that do to your kind of mental health and your security in the world? All those kinds of things have not been considered. So there was a huge richness of discussion, some of which we haven't analysed yet. It's all on a video link that we will look at and go through. So there was a huge amount of things discussed. But they're roughly the things that were discussed. About going back to school, I think some of the young people's views on the practical stuff is very important to hear. How do you socially distance 6-year-olds, 7-year-olds? But then how do you socially distance older children by groups, by age, by classes? And a lot of schools don't have massive areas or footprints where you can socially distance classes of 50, 40 people. So lots of sensible stuff like that. So I do slightly worry. I kind of also agree with Sarah in a way, and I've pushed for children to maybe go back to somewhere like a school that's safe. But there are practical and safety considerations for young people. And although COVID seems a fairly benign disease, we do have a group of children who've been badly affected. And they were children who, surprisingly for us, didn't have healthcare problems before. So the TMS inflammatory group seem to be children who haven't got a problem before, have come in with a post-COVID inflammatory condition, which can be quite serious, with heart failure, coronary artery problems, need for huge amounts of immunosuppression. And some of those children go on to develop chronic problems that might last with them for life. So although it's a small number, when you look at the larger number of children out there, it's still a concern that we don't quite know how likely it is that children will come down with that.
Thanks, Joe. Great. Okay. Look, guys, sadly, we are now out of time. It's 2:05, so everyone wants to go to work. We've had over 100 people participating with this ground round. It's been fantastic. Thank you, Joe, David, Hugo, Mariana, Sarah. It's been very interesting, and clearly these discussions could go on all afternoon, I'm sure. We're going to release, we'll edit the video together and we'll release that onto the GLA YouTube channel for everyone to see. If anybody can give us some feedback via the SurveyMonkey link, which will come up in a minute, and if you want CVD points, please put your name on there and we can send you a certificate if you need that for your appraisal file. And next week, don't forget to log in next week. Grand Round is about well-being. There's the slide there with the details of next week thing. Downjit and Mandy are going to talk about the well-being of staff during the COVID-19 pandemic, which is something we did actually touch on today as well, and something we're all interested in. But thank you again to Joe and our fantastic panel. and we'll see you next week on Wednesday, the 3rd of June.
Thank you.
Thank you.
Thank you.